We're going to talk about MRD in lung cancer. These are our disclosures. We have to remind us that the MRD typically is we're talking about minimal residual disease after surgery, but if you think about, we very much also need to use the same technology, ctDNA, for monitoring tumor response in stage 4 and also to prevent recurrence. And actually, we have many more stage 4 patients than post-surgical patients, so that's why a lot of us are doing a lot of ctDNA measurement in metastatic disease, as we always show. This is one example, for example, from our center. We just presented this poster in the World Congress of Liquid Biopsies. Basically, we are trying to see what is the best time point to measure ctDNA, for example, in patients with metastatic disease. These are our patients with metastatic disease, and in general, you can see everybody knows that ctDNA is already validated as prognostic. The challenge is to make it predictive. No? This is a typical case of prognostic. If you have ctDNA positive, your progression-free survival is inferior than if you have ctDNA negative, and it can be done longitudinal, so several measures, or it can be done at a landmark. No? For example, typically we start a TKI or immunotherapy, and 3 months later we do a landmark measurement, and it's very predictive. No? This is another study. This was presented in World Lung for Dr. Becerrano. Basically, here we are doing ctDNA measurement after surgery. This is the typical MRD, or ctDNA measurement after adjuvant therapy. These are 2 groups, 197 patients. And what we see is that the ctDNA negative during the MRD window that was after surgery was associated with improving relapse-free survival and improving overall survival, as you can see in the graphics. After adjuvant therapy, we see more or less the same results. No? The presence of the ctDNA positivity was associated with a reduced relapse-free survival. This is checkmate A16. We are trying to validate the ctDNA as a biomarker, but you know that in neoadjuvant approaches, I guess the best predictor is the complete pathological response. So that's why in A16, like in the other perioperative trials that we have, like 671, 772T, etc., complete pathological response is the best predictor of outcome for the patients. However, we are very, very close to have ctDNA, because in this study, ctDNA in a little bit less than half of the patients correlate with complete pathological response. One of the challenges, because they told me to talk about challenges, is, for example, only 25% of the patients here were able to have the ctDNA assessed. Okay, so that's why part of the challenge is we cannot measure ctDNA in everybody. This is in Power Lung 1. You remember this is the cemiplimab study. We validated cemiplimab with this study. Patients with PD-L1 positive, they got cemiplimab versus chemo stage 4, and you know that that's why cemiplimab was approved for this. But during this study, there was also ctDNA assessment. And here, for example, we are not doing one landmark. What we're assessing here is clearance. Maybe the best way to do ctDNA is measuring clearance. So here, they have total clearance, more than 90% clearance, less than 90% clearance, or increase of the ctDNA. So as you can see easily in the blue and green curves, in the cemiplimab, for example, the more than 90% clearance of the ctDNA, or the total clearance of the ctDNA, really correlates with response. And of course, if you increase the ctDNA like in the red, you don't do very well. So maybe this is the best way that we can use ctDNA, measuring clearance instead to do time points. This is how we're going to make this a standard of care, because ctDNA is not standard of care. We do as a research. We need to use the ctDNA to guide therapy. No, that's why this presentation of Julia Roto and ASCO, I like it a lot. So these are patients that have metastatic disease. They are PD-L1 positive, and when you have PD-L1 positive, you can give IO or you can give chemo IO. And these patients were treated only with immunotherapy alone, but if they have a response, meaning radiological response or the ctDNA response, they will keep on immunotherapy. While the patients that didn't have a radiological response, or they have an increase of the ctDNA, they escalate therapy. So instead of give only IO, they added chemo. As you can see in the right side, the survival is obvious. No, patients that have a plasma response, they do better than the ones that don't have a plasma response. But the day that we're going to make ctDNA a standard of care is going to be that we can do plasma guide therapy for these patients. When we talk about ctDNA, we have two options. You know that we have the one called tumor-naive. We also call them tumor-agnostic. We also call them plasma-guide, or the tumor-informed. The tumor-informed is when we go and we do a whole exome or genome sequencing of the tissue, and we look for truncal mutations, and we prepare, so in that way we can assess that in the blood. But that's what we call them tumor-informed. The challenges of tumor-informed is probably the most sensitive, no? But the challenges is that you need tissue. So in some of the cooperative studies, sometimes we only have 20 or 30% of the patients that we can prepare, because if you think about, we are already using tissue for histological confirmation that you have lung cancer. We have a big challenges to do NGS. Now we need more tissue to do MRD, so that's why it's becoming very, very challenging to get enough tissue to run these tumor-informed MRDs. That's why another option is to do the tumor-naive. So, and the tumor-naive, we do the single nucleotide variant assessment similar to the tumor-informed, but we also use methylation, fragmentomics, other technologies to try to match the sensitivity of the tumor-informed. And this is, for example, at the landmark point in early-stage lung cancer, patients that have recurrence-free survival or overall survival, depending of the presence of ctDNA. And it's obvious, I think, that the best way to do the ctDNA is in a longitudinal way instead of a landmark. And also, we have, for example, the same investigators that did the landmark studies. We have some longitudinal, and then you can see that sensitivity and specificity increases as you change the ctDNA. So most of the studies that we do in our cancer center, we have like 6 studies for MRD now. We measure every 3 months for 1 or 2 years because it's more accurate than doing only one landmark at some time point after surgery or during the treatment. No? It's very interesting to know that maybe also for patients that are that go early stage go for surgery, I think it's better if we do the MRD before surgery with the tissue from the biopsy, because we already know before surgery if that MRD is positive or negative. Because a very practical question that one time I told a patient after surgery, hey, great news, your MRD is negative. And the patient said, but how do you know that was positive, So, I know, we assume it's positive. But with all of these challenges that I'm talking about MRD, it's better to do it before surgery, and you have proof that the patient has tumoral ctDNA, so we can follow them after the surgery. And now we are improving the technology, So we have, if you see the TracerX publications, we start to do this with whole exome sequencing, Signatera, for example, looking for 16 truncal mutations. Now we have whole genome sequencing, and the amount of single nucleotide variants that we can look for are around 1,800. And that's it's called Personalis, and this is what is in the publication of the TracerX. So the sensitivity and specificity increase a lot. Another way that we can increase sensitivity and specificity and get rid of the background noise so we get more accurate testing is to use the FAST variant sequencing. If you know Max Dien, his group in Stanford has been publishing this for a while. Basically, they look for multiple mutations in one fragment instead of only a single one mutation, and now they can detect 1 in a million. So the level of detection can go as low as 1 in a million. So that is why this is more accurate. And this is an example. The same group, Foresight, they have here a comparison when we used to do the original MRD. You can see in the graphic the level of detection. With now this fast way to look at MRD, the level of detection went down to 1 in a million. You can see in the upper right that the detection using the FAST is much higher for stage 1, 2, and 3 in blue than the original MRD that they used before. And you can see, of course, in the bottom, in the 2 graphics, that the original test, the single nucleotide variant, is used to differentiate, the patients that are positive or negative, the freedom of recurrence. But the new one is much more accurate. You see the curves separate much better, so it's a much better test. This is a presentation in World Lung of our friend Natasha Late. She used FAST here for first time, and she has her own data. And what they did is they compared, again, same as the group of Max, They compare the original data in the right, the first generation test that they use is only in gray. You see how the ultra-sensitive ctDNA with FAT-SET improved tremendously the level of detection. No? In the lower right, you can see in the original MRD that they have, they used to be able to detect 22% pre-op. Now it went to 68%, or post-op 2%. Now they went up to 38%. So this has allowed to have a much more sensitive test. So maybe with this technology, we finally will be able to establish the ctDNA as a standard of care. But there are other challenges. You know, why we have to blame the ctDNA for the lack of sensitivity, specificity, lack of technology when we don't have good drugs. Okay, to be honest, that's what I was thinking about. This was, if you guys were in ASCO, this was a presentation that called my attention, you know. This is a very good study about ctDNA. It's called Dynamic-3. Basically, the patients have a stage 3 colon cancer, and after they were given a standard of care, or the other cohort was they guide therapy based on ctDNA. And of course, the idea is if we guide therapy, we get a better outcome. But didn't happen. Didn't happen. You see the course in the right? If you guide therapy with ctDNA, you get the same response. So everybody can say, oh, this is a disappointment, ctDNA doesn't work. No, I blame the chemo here. They get this lousy chemo that you know, that is FOLFOX or KPOX. You can see in the bottom, from the patients that were ctDNA positive, the people that needed treatment, they were only able to clear 28%. Meaning the chemo was only 28% effective. So how come we are going to have a successful guide therapy if we don't have a good treatment? So that's why my thinking. The only good thing of this study, because it's a good study, is doing guiding therapy. If I remember, they were around, only they gave chemo to around 15% of the patients. Using a standard of care, they gave chemo to 28% of the patients. So, and the outcome was the same. So if you want to be optimistic, you can say, okay, but at least guiding therapy now, I can avoid giving chemo to 13% of the patients, and I'm getting the same outcome. So we're moving to the cost-effective quality of life also for the patients, no? And this is one of the best studies that we have, and it's not in lung cancer, it's in bladder cancer, you know, in Vigor 11, if you came to ESMO. So this is the last two. I know this is a lung cancer conference, but we don't have good studies like this yet. We're a little bit behind in research. So in Vigor 11, if patients that have bladder cancer, after the adjuvant therapy was guided. So if you are ctDNA positive, you get therapy with atezo. If you are ctDNA negative, you don't get therapy. And as you can see, the study was positive. The study was positive, and that's why for the ones that are fans of ctDNA, this is our flagship. You know, we say, oh, you know, now we're changing the standard of care, at least in bladder cancer, soon in colon cancer, and hopefully soon also we can do similar studies, or we have positive studies also in lung cancer like this, so we can change the standard of care. But there are also other technologies. Well, maybe you say, okay, the ctDNA is not technology. Why we don't look for others? So another way that we can do is we can do tumor fraction. You know, tumor fraction is famous because if you remember, for example, we have a lot of publications that liquid and tissue is the same, but liquid and tissue is the same if the tumor fraction is more than 1%. As you can see in the right, if the tumor fraction is more than 1%, the tissue doesn't add anything. But if the tumor fraction is less than 1%, we still need the tissue to find some genetic aberrations, especially fusions, because there is not enough amount of tumor. And of course, the tumor fraction can also be used, you can see in the bottom. For example, in this publication, they use 98% as a cutoff. No? The tumor fraction more than that, less than that, you see the difference in outcome. So we can also measure tumor fraction. Another one is fragmentomics. You know, if you look at the top, these are in gray, the fragments of healthy cells. But when you see in the bottom, the fragments of cancer cells are usually very big and very aberrant. So that's why fragmentomics with technology, with methylation, can allow us also to track tumor. So maybe the solution is not only keep pounding the ctDNA, maybe we can use tumor fraction, maybe we can use fragmentomics, we can do other things. So in conclusion, we have two options. We have the tumor-informed or the tumor-naive assays, and we still arguing which one is better. I'm telling you, everybody says, oh, tumor-informed is better because it's more sensitive, but I already told you, the problem is we cannot make tumor-informed for everybody, so that's why we need tumor-naive. So for example, in our center, what we do is we order tumor-informed, we do Personalis or Signatera in everybody. If we cannot make it, we use tumor-naive. We will have research with Gardan, so we use tumor-naive when we cannot make tumor-informed. In that way, all the patients are going to benefit from one of these technologies. What is the ideal sensitivity and specificity? Now with the Personalis, we're reaching 1 in a million, and maybe that's what we're missing, and that's why until today is not standard of care. How many endpoints we should use? Well, it's obvious that longitudinal measures at several endpoints is better than one, and the ideal studies, as I show you, is we have to escalate based on MRD status so we can show the validity of the use of MRD. And finally, we need better drugs. You know, we cannot blame the MRD for the lack of success because until we have better drugs. Thank you.